So my name is Patrick Cheboi, the sub-county TB and HIV coordinator for Ijara sub-county. In Garissa County, we have 7 sub-counties, Ijara being one of them. So it has an estimated population of about 134,000 people, and it has 11 public health facilities and about 9 private facilities. And the 11 healthcare facilities are providing HIV services, but 3 facilities are currently not providing due to closure of facilities due to shortage of staffs. So the major people who are living in this area are Muslims, though the town is cosmopolitan, but the majority of people are Muslims, the Somalis, and it's a hard to reach area among the ASAL counties. And these counties of ASAL areas were said to have high index of stigma and discrimination, and that one is affecting our programming of HIV and TB activities. So in terms of HIV services, the first thing, these people do not believe in this issue of condom, especially the previous outreach we did. Even introducing this condom in health talk, it was a problem because these people don't believe in this thing, and they believe that these condoms will destroy their children. So they believe they stick to their culture of just being faithful to their partners and abstaining from these activities. So in Ijara, we have about 73 people who are living with HIV, and those one are the ones who are known. But there are some, maybe there are some who are not diagnosed, or they are taking medications far from the place due to stigma. So we have a lot of clients who are going to Pengine, to Hola or to Garissa to pick their medications, because in this area there is high index of stigma. So they prefer going to far places to search for the services because of the stigma. So this issue of stigma and isolation is real, because we have about 2 children now. There's one child who was diagnosed with HIV positive, was staying with the grandmother. The mother died. So, but they were fearing this community may know the status of the child. So they were not bringing the child for treatment, and the child stayed for about 1.5 years. But unfortunately, due to the viral suppression, which was poor, the child died. So the other case, we have 2 children who we have been following for the last since 2014, when the mother died, who are born with HIV. Initially they were being isolated from the community where they were living. They were chased away, so they remained homeless for some time. They were assisted with a place by the government in a CDF office, where they spend their time there. But the problem of food security was there. At times they are being assisted by the DC and the well-wishers, but these people were isolated, and they were not enjoying their rights of free of association. So in terms of education, the first child dropped out of education due to lack of support, but the other child is still in school. She's about 15 years now, but she's continuing the education. But there's still this element of stigma which is going, and it's affecting their livelihoods. So these children are staying by their own. They live with their father, but their father is unemployed. But the first child who is about 22 years now, is doing some small scale business, selling milk in town, but this one is unable to sustain them. So when there is some ration from the DC, when we have maybe rice or beans, we assist them, and it just boosts them to boost their livelihoods. But in terms of education, they have real challenges, and another problem is housing, in which they are being given a room, but it's not such that conducive. So for the last 2 days, we were privileged to have people from the National Systemic Diseases, previously called NAC. So they came the first day. They did an entry meeting, where they found the gatekeepers of the area, that is the chiefs, the imams, the youths, the networks for people living with HIV. So they sensitized the community on awareness of HIV, manena HIV self-test, and also condom distribution. And also we told them on the options which we can have for manena PrEP or post-exposure prophylaxis, which is available in our facility, and it's underutilized. So also the following day now, we did an outreach in some places. So the first day we went to a place called Gababa, Ijara, and Ruka. So in these places, our challenges in the first day, the first time the community needs some integration of services. When you take the services of HIV alone, people will not take it seriously. So we did integration. We provided other services like treating of common illnesses, giving immunizations, and also screening for HIV. So we did an integration so that we can attract people, so that uptake of these services can be good. So in places like Ijara and Ruka, we were unable to demonstrate condoms because of the facility and the community which do not accept this service. It's a challenge. So from the experience, doing a standalone program is not such that effective, but integrating other services, like now when we have an outreach for HIV, we include other services like immunizations, doing deworming, treating common ailments like maybe people have some infections, they have something like typhoid, or they have other concerns which are to be addressed. So we took some few drugs which we gave to the community, and those who require other specialized treatment or investigations, we brought them a prescription to go to the sub-county hospital for care. So as I said, this Garissa County is one of the ASAL counties, and assessing healthcare at times is very difficult. Because in a place like Ababa, Saizi, currently there is no healthcare worker. So assessing healthcare worker, they have to come to the sub-county hospital, which is about 25 kilometers, and it's expensive to some of the clans. So giving outreach and currently there's a drought which is there, and so people have migrated towards the places where they can get water and other resources. So going near to these people is very helpful, and it's assists in giving services to these people. So the first thing is maybe to continue with advocacy and communication and behavior change. This by giving regular health talks to the community, involving the community strategy, the community leaders, informing them about HIV and other services which are available, and telling them these are free services, and HIV is just as normal as the other conditions. If you have it, it's not a death sentence, and you can get treatment, and you can stay like other people. So in this sub-county, usually we don't have a designated place for this youth. We don't have a youth-friendly service in which maybe we can coordinate with the sub-county MOH, and maybe when there are some donors, where we can create a place where we have youth-friendly services where they can come and get their services as required, so that we can upscale awareness on HIV, uptake of HIV testing services, and we can prevent new infections. So the current settings, these youth, they may fear their parents, because when they go to the clinic, they don't know whether they'll meet their parents or somebody who is of the same age of their parents. So they fear coming, but there are some few come, but they have to assess the place. If it's secure, that's when they can come. But when they find somebody whom they are not comfortable, that one will be a missed opportunity, and they'll not come back for the service again. So for the PMCTC, the testing is pretty good, but our problem now is the partner involvement. In Garissa County, we have the highest MCTC rate of about 28%, and this one may be due to maybe late diagnosis, or maybe the mothers are not taking medication properly. That's why we have a high rate of transmission to their children. So we need to empower these health talks in maybe clinics. We can involve our male partners. Maybe some are fearing to take medications for fear of stigmatization. So this one increases the chances of transmitting to their children. So for the outreach we did for the last 2 days, that is in Gababa, Ijara, Ruka, Kotila, and Masalani. When we gave the health talks, we found that there are some very big knowledge gap on HIV services. These people believe that this disease is not within the Somali community. They believe that this one is in other places and it's not among them, and they don't like talking about this condition. So that one was the greatest challenge. So maybe if we can get support for giving more information to the community, it will be of very helpful.